So we're going to talk a little bit about emergencies that we see as otolaryngologists, and with the first part really being some things that you see in your offices and that you can be apt to take care of acutely. Epistaxis, peritonsil abscesses, acute sensorineural hair loss. I'm only going to make one quick comment about that because Dr. Volker is going to talk about that. But sinusitis emergencies, facial fractures, and of course, pending airway emergencies. So epistaxis, nosebleeds, it's of course now, it used to be most common in winter months. It's now 12 months a year with all of the anticoagulants that patients are on. When Coumadin was the only one, we'd only see a spattering of patients on Coumadin, but with now all the new Xareltos, Pradaxas, all of those different anticoagulants, we're seeing nosebleeds now 12 months a year. Of course, with hypertension, control the blood pressure in your offices. In children, cut their fingernails. Kids pick their noses when they're asleep. And if you ask the history, when are they nose bleeding? Most commonly, it's early in the morning. When you have a strategy to take care of something, you really have to have the tools and the preparation beforehand. So a light source is very important. Headlight, for anything that you do, lighting is, seeing is believing, and having good lighting is important. And using local anesthesia with epinephrine. I was trained to do many surgeries, especially in the VA, with just under local anesthesia, and it was invaluable now in my practice. So this is Kesselbach's plexus. This is actually a patient that came in with 6 years of recurring nosebleeds. She had seen other doctors, but this is what I found in her anterior areas, the most dramatic Kesselbach's plexus I had ever seen. And she actually used, I used electrocautery to cauterize those large vessels. But she came in and she said, well, I get nosebleeds. How bad are they? Well, it squirts across the room. I said, well, it's a pretty bad nosebleed. But initially, when you have patients with recurring nosebleeds, make sure they have cotton balls and Afrin. And you know, the old saying, just hold your nose closed is great, but if you place a cotton ball with some Afrin in it and then apply pressure, it will stop in most of the times. So there's 3 areas, major areas where nosebleeds occur. Of course, 80% of them in area 1, and there's some important anatomic pearls to know about that to control them. The second area is the anterior and posterior ethmoids, and the third area is the sphenopalatine posterior nasal artery. We're only going to address the 1 zone because 2 and 3 are really major bleeds, and especially the posterior nosebleeds when the flow of blood is going posteriorly. It's not, and those patients are usually showing up in the emergency room and not the common Pradaxa, et cetera. Although almost all patients with nosebleeds will develop blood on the contralateral side and clots, and we're going to talk a little bit about that and what to do. Training and preparation. A nosebleed is a horror show. I can tell you that every single patient thinks they've bled out, they're going to pass out. In their bathrooms, it looks like Freddy Krueger was there. They bring pictures of the blood all over the place, and I always tell them, you have more than enough blood, don't worry, but they are very anxious and very scared. And because of that anxiety and fear, their blood pressure is up. So one of the things, if you don't have sedation in your office, make sure you have some Valium. Even if they're going to the emergency room, give them something to calm them down. Having the equipment and strategy to control the nosebleed is key. So this is our basic nosebleed kit. The sinus rinse bottle or a bulb syringe, Afrin, topical Ponticaine, or even topical lidocaine works on the mucus lining tissue. Silver nitrate and the 30 gauge and long 27 gauge needles. These are examples of some balloons and tampons. In your offices, you should have at least one of the manufacturer's components of this. And I know that a lot of people don't like putting them in because they're painful, but I'm going to show you how to do it without much pain. The balloons need to come out within 24 hours because they really create a lot of pressure and they can cause necrosis. Oops. So if you see the bleeding area, which it's not hard to see in the anterior nares, put a little topical anesthesia on it, even 2% lidocaine, and then cauterize it with the septic pencil or the silver nitrate. If you can't find it, you send it over to us, and a fiber optic endoscopy will be performed. In the emergency room, nasal packing is usually placed blindly by the emergency room, either balloon packs or Maricel, and usually the non-balloon ones are left in for 3 days. But the balloon ones should be out in 24 hours. Here's a takeaway. And this is a documented study. Nasal lavage. So they had 65 patients that had posterior nosebleed. It was controlled with simple nasal lavage, 65% of the time, with 50 cc's of warmed 500 ml lavage. And you could do it with a bulb or the rinse. Why this works is because of two things. As soon as a clot occurs, the anticoagulant factors are excreted, so that creates an anticoagulant or environment, and also the clot can be holding the artery open in the mouth, and just getting that clot out of the mouth out of the nose is helpful. The emergency room nurses hate us or hate me when I tell them wash out the nose because it's not a beautiful thing, but it stops in many, many cases. And the other key is doing a simple injection at the anterior base of the nostril because the main greater palatine artery, incisor canal artery that feeds the bottom of Kesselbach's plexus, can be controlled by the epi, but also you get a nice anesthetic. So anything you do in the nose, if you put packing in, is not as painful, and of course the bleeding improves. And that's about a centimeter back from this area. And this is an example of a patient that was bleeding, and unfortunately, let's go back. Well, for the sake of, I could show this, but it's basically you take a 3 cc syringe, and right at the base of the nostril here, you inject about 2 cc's, and it will track back along the bone, and you'll get a nice anesthetic, and if it's just Kesselbach's plexus, many times it will stop. Peritonsillar abscesses. A lot of times primary care will see these and really get nervous, and this is low-lying fruit because that abscess is right in the view, and putting a needle into it, you can really advocate for the patient's pain. Presents with unilateral swelling, deviation of the uvula, swelling in the angle of the jaw, hot potato voice. It's not that difficult to diagnose. So this is what you have, a simple 10 cc syringe, a spinal needle or a 22 or 18 gauge, 1% xylocaine, and after Decadron, Unison, or Cleocin. And these are examples of peritonsillar abscesses. Trismus is almost pathognomonic. If patients are having a hard time opening their jaw because the irritation of the pterygoid muscles, it's most probably a peritonsillar abscess. And as you see there, the abscess is right in view. Where to put the needle safely? So you draw a horizontal line from the molar, a vertical line from the molar straight up, a horizontal line from the superior pillar of the contralateral tonsil, and as you see right there is a spot where you can safely put the needle. And this is an example of draining a peritonsillar abscess very simply, locally, and the patients immediately get great relief. This is put in there so you can see the things that everybody is afraid of is the carotid artery and putting the needle into the carotid. The abscess almost protects you from that. And as you see here in this CAT scan, if you stay medial to the molar and just superior to the contralateral superior pole, you're going to hit straight dead center in that abscess and drain it. The carotid arteries are lateral. They are protected by the pterygoid muscles. Unless you go at a trajectory laterally with your needle, you rarely hit it. I've not heard of anyone hitting a vascular structure by doing a needle drainage of a peritonsillar abscess. So don't worry about that. Quickly, Ludwig's angina. What's this? It's usually related to dental origin, but it's a submental cellulitis. It is a real emergency because these patients, at least 70 to 75% of the cases, need airway control, either via tracheostomy or via emergency intubation. It's not an abscess, it's a cellulitis, tender, firm, usually dental issue, hot potato voice, tachypnea, dyspnea, all related to the infectious systemic process. As you see, abscesses in the upper airway, 5% require trach or airway, and Ludwig's angina, 75% in 200 people. Quickly, Dr. Volker is going to talk about this. This is what I would recommend. It's something that we found. It is practical, easy, simple, and you can get a really valuable hearing test, and your MA can administer it. They don't have to do anything. It's done on an iPad with high definition headphones, and the iPad is sold by the company with changes in the software to be able to get 250 hertz up to 4,000 hertz. A normal iPad does not have that ability. So you really can't get a valuable hearing test. And this takes about 5 minutes. And for screening audiograms for every primary care, you should be doing them as part of your wellness exams on every patient now that you have a simple option to do it. And it's reimbursable. Screening audiogram pays $80 by Medicare, and it's valuable. When patients come in and say, how's your hearing? Oh, my hearing's fine. Well, hearing loss is a silent disease. You should ask their spouse or their bedfellow if they're hearing well, and they'll tell you the truth, because if you haven't heard it, you don't even know it existed. So the subjective aspect of hearing loss is a big issue. So this is a really great, easy aspect for primary care. Quickly, orbital cellulitis. This patient, as you see, has ophthalmoplegia. He can't move his eye, and he's got an orbital abscess that was drained intranasally. Of course, immediate surgery and IV antibiotics. Quickly, facial fractures. Facial fractures have dramatically decreased because of seatbelts, number one, but then on top of that, airbags. And as you see here, the statistics have really changed since the advent of that. Most of the facial fractures that we've seen were usually related to car accidents. And of course, this is orbital zygomatics are the most common, secondary to nasal fractures. When you do have a nasal fracture or a zygomatic orbital fracture, you have to tell the patients not to blow their nose. Because I've seen it probably 20 times where patients would sneeze or blow their nose after a fracture, and then they develop a pneumo-orbitum. And this is an example of a patient with that. Here's an orbital blowout fracture, as you see on the right side. And the key with surgery versus no surgery is entrapment or enophthalmos, or no entrapment or enophthalmos. And here's just examples of the inferior rectus being entrapped in the fracture line, and then just fat herniating down, which is a non-surgical case. Here is an example of one of our Kings players this year who developed a fracture from a slap shot. And he had a pretty dramatic orbital nasal fracture, as you'll see in a second. Penetrating injuries are not common, but in ice hockey, they do happen. And so there it is right there. And here is the fracture. His entire midface was depressed about 1.5 centimeters, and this is the reconstruction. When he woke up in the recovery room, he said, "Can I get on the ice tomorrow?" I said, "No, let's give it a couple of days." So here he is, 3 weeks after surgery. He scored in his winning goal in his first day back, and here he is there. Pending airway obstruction. Here's another hockey player that got a puck in the jaw, which caused a very rare sliding door fracture with fracture fragments in the tongue. The management algorithm is obviously oxygen, 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 getting it some way into the obstructed airway, either by an ambu bag, a laryngomask airway, or even just transtracheal oxygenation. And this is a very simple way of transtracheal oxygenating someone with an ambu bag, or just putting a needle in just to deliver oxygen. And this gentleman, as I was saying, had an emergency airway so severe that his tongue was prolapsing out of his mouth, and that obviated any IMF, but he did just fine. So having said that, thank you for listening, and those are a couple of emergencies that we did.